mute yourself. You can feel free to turn on your microphones, but if you're not speaking, kindly mute yourself so that there's no background noise. So thank you very much, and good afternoon, good morning, and good evening to colleagues joining us from all around the world. We welcome you to our third webinar series focused on One Health and COVID-19, hosted by Africa CDC. This session is going to be rather interesting as requested by many of our member states and many of our experts. There's been concerns around occupational risk that COVID-19 presents. So this session, we're going to be discussing occupational risk at the human and animal interface. On my panel today, I have Dr. Samuel from OIE and Dr. Catherine from the Animal Medical Center, United States. I also have Dr. Emmanuel from the Veterinary Service Directorate, Ghana. And finally, I have from Infection Control Africa Network, Professor Olayinka. My colleague, Dr. Stephanie, would be highlighting the global and the continental COVID-19 situation updates. I say thank you very much to all our participants for being a part of this. We're looking forward to a very fruitful engagement. Just a few housekeeping rules. I know that we'll have so many questions, so many comments. Please feel free to put your questions on our Q&A box, and also feel free to drop your comments on the chat box. All of the questions that will be asked at, during the moderated discussions will be questions that have been dropped on the Q&A. All my panelists will be available to answer all of your questions. So feel free to start dropping your questions and comments onto the Q&A box. Please kindly mute your mics if you're not speaking. I would also indulge that. I will also request that my panelists keep their microphones turned off when they're not speaking, and feel free to turn on your video whichever way you're comfortable with. I can see some people are starting to raise their hands, and I would just like to say that for this session, we will just be taking questions that have been put in the Q&A box or questions that have been put in the chat function. So on behalf of the Director, Africa CDC, Dr. John Nkengasong, I welcome you to this edition of Africa CDC One Health and COVID-19 webinar series. And I hope that we'll have a very engaging and fruitful discussion. And most importantly, we'll be able to learn from each other. So on that note, I say thank you very much for being a part of this, and thank you for joining us. My colleague, Stephanie, will take us through the global and continental COVID-19 situation update. So Stephanie, over to you.
Thanks so much. And it looks like I just need you to stop sharing, and then I can take over. All right, awesome. Thank you so much. All right, give me 2 seconds to get the slides up, and let me know when you guys can see them.
Great, we can see your screen now. Perfect.
Okay, so I'll keep it brief since we have so many wonderful speakers today. Just to give you a quick global overview of the coronavirus situation. Currently, there are over 24 million confirmed cases and just over 830,000 deaths being reported. You can see from the graph on the right that the region of the Americas is reporting the vast majority of new cases daily, but then also the Southeast Asia region is also reporting additional cases. They're starting to report more and more cases daily as well. So 2 regions to keep an eye out on. Within Africa itself, this is currently what the epi curve looks like of new daily cases. And you can see the vast majority of those are being reported from the southern region. And if we actually removed South Africa, you would see that this curve is actually a lot more flat than it currently appears. So that rise and fall is really directed by what's happening currently in South Africa. Currently across the continent, there are just over 1.2 million cases being reported and just over 29,000 deaths and just over 975,000 recoveries. If we look over the last 24 hours, there have been just over 7,000, almost 8,000 new cases reported and 150 deaths reported. Again, the majority of those are coming from South Africa, but within the eastern region, Ethiopia is reporting an increase in daily new cases, as well as Morocco in the northern region. This is the breakdown of cumulative COVID cases by the AU member states. And you can see that the vast majority of member states are still reporting less than 5,000 cases. And if we look at the COVID cases being reported by population or the cumulative incidence, you can see that the vast majority are reporting between 10 and 100 cases per 100,000 population or less. And with regard to testing, over 11 million tests have been conducted to date. And that puts Africa, the continent of Africa, at a test per case ratio of 10. And according to WHO, that is within that adequate testing range. Usually you want to see between 10 to 30 tests per reported case that's the ratio that you want to see being reported. And that's just the overview from us. If you have any other questions, please feel free to reach out to us, our EBS team, as well as visiting our website. Thanks so much.
Fantastic. Thank you very much. My next speaker is Dr. Samuel from OIE. Dr. Samuel will be walking us through animal event and guidance from OIE. So thank you very much, Dr. Samuel. The floor is yours.
Okay, good afternoon, everybody. Mine, as you have been told, is just to give you the status of animal events and the OIE guidance of reporting SARS in animals and guidance of protecting animal health workers. So, my presentation is going to be in 5 short parts. I'll show you just factors increasing the emergency of zoonosis and the economic impact, the origins of the SARS-CoV-2 and the animal events reported in the world, and the guidance on how to report in animals and the protecting human workers. Now, when you look at the factors that are increasing the emergence of zoonotic diseases, there are several of them, but I just wanted to give you an idea that over the several decades ago, we have had several zoonotic diseases breaking out in different parts of the world. They are not limited to any particular part of the world, but there they are, as you can see from there, the latest being COVID-19. And so many factors have been attributed, interplaying with one another sometimes. Not necessarily any one factor is involved, but we can see there some of them could be involved in the emergence of zoonotic diseases. I'm not saying that this is what is involved in the SARS-CoV, but all these factors can actually influence the emergence of zoonotic diseases. Now, if you look at the economic impact of the infectious disease outbreaks, most of them, if you look at the impact on agriculture, travel, tourism, and other events like mining, you find that the SARS outbreak in China and Hong Kong cost about $50 billion US to China, Singapore, and Canada. And if you look at avian flu worldwide, basically in poultry production, it was about 30 billion. And worldwide for H1N1 is about 55 billion that was impacting actually on pig production, travel, and the tourism and public events. The Ebola outbreak in West Africa is estimated to have cost about 10 billion on mining alone. Zika in Latin America, about 18 billion. Now, according to the recent estimates of the United Nations and others, says that COVID could actually cost the economy about up to 15 trillion US. And this triggering a lot of global recession, forcing the introduction of costly and stimulus packages. So having said that, what's the origin of the SARS-CoV-2? I give this slide credit to Bill Koresh, who is the OIE working group staff and EcoHealth Alliance. We know that zoonotic origin of coronaviruses are now clearly linked to bats. There are 7 known coronaviruses in humans. 5 of them will cause mild diseases, and 4 of them cause severe diseases. Almost all have got zoonotic origin in animals. For example, in humans, we have bats and camels responsible for the 22.9E variety. We've got several, like for example, SARS events, civets and origins in bats has been speculated. The MERS-CoV, we've got camels that have been implicated, but the origin is probably bats. But none of the human COVID viruses, such as the porcine epidemic diarrhea virus, may have emerged by host switching. The recent outbreaks that we have had in coronavirus actually cements the place for the coronavirus as a concern for human zoonotic diseases. I don't need to go through this. It has already been shown. We've got about 24 million cases so far, and about 820,000 deaths globally. So what are the animal events across the world? You will note that the ones that have been reported, which we have either reported to OIE or some credible sources, we have cats, dogs, tiger, lion, mink, and puma. Most of these have been reported in areas where the COVID outbreak has been actually quite high. In Africa, it's only South Africa where an event has been reported in an animal, and that's a puma in a zoo situation. The mink story is a bit interesting. It's mainly the Netherlands, Denmark, Spain, and of recent, it has been reported in the US. So what are the research findings in animals? Some research findings done by the Frederick Loeffler Institute, which is a collaborating OI laboratory, has found that pigs and poultry are not susceptible. They don't seem to show any clinical signs, and there seems to be no transmission. We have animals that seem to have very high susceptibility, and that includes the cats, the tigers and the lions, the ferrets, the minks, the fruit bats, the Egyptian fruit bats, the golden Syrian hamsters, and some monkeys. The mink story that I have just told you is one of the most interesting because it shows that there is transmission between the animal and animal, and perhaps, not perhaps, but it's actually transmitting back to the human beings. So this is the only case that credibly shown that at the farm level, because minks are kept in farming conditions, they can actually transmit to humans. We have no record of credible record of any disease outbreak in livestock. There is the potential infection for other animals, and you will find that when the study was done by the genomic analysis of the mammalian species, it shows that there is a potential for SARS-CoV to be infected in several mammals, and the risks are very high. We've got the chimpanzees, the western lowland gorilla, and the gibbons, which can actually get infected by this, which can actually be highly impacted by this virus, because the receptors for the virus on the cells are very closely, very similar to the human beings. We've got high incidence of the white-tailed deer, as you can see there, medium range in the Siberian tiger and sheep, cat, and cattle, low in the pigs and horses, and very low in the animals that you show there. This is based on genomic analysis of the potential for infection, not necessarily that the virus has been shown to go through. So when you look at that, it means that if this virus perhaps went into the chimpanzees, it might actually cause a devastation. These are endangered species, and the gorillas are critically endangered animals. And based on the genomic analysis of the AC2 receptors, it shows that this is the criteria, this is the range from high susceptibility to very low susceptibility. The raccoon dogs under experimental conditions have been demonstrated to be a potential for intermediate host. And this is based basically on the high level of virus shedding, minor clinical signs, seroconversion, and the absence of viral adaptation, which means that the virus goes in, does not mutate, it comes out and can be transmitted. So what is the OI guidance on reporting for SARS-CoV in animals? First of all, I want to let you know that SARS is an emerging disease, which means that as defined by the terrestrial code, it's a new occurrence in animal of a disease or infection or infestation, which can cause significant impact on animal public health, either resulting from achieving a change in the pathogenic agent spread to a new geographical area or previously unrecognized pathogenic agent. That's the definition of an emerging disease. Given that background, in the framework of incident management system, OI has put up several ad hoc groups. We had the wildlife permanent working group, but then OI also developed COVID-19 and human-animal ecosystem interface ad hoc groups to look at various aspects, what can, and give reports. And the objectives are shown there on the slide. You will be able to read later and be able to decipher it for yourself. But what I want to let you know is that, for example, if you look at the veterinary laboratory support, a report has actually been given that provides a comprehensive, a fairly good description on how to use the veterinary laboratories for testing human samples. It shows you about regulatory affairs for the national level must be taken into consideration, how to continue doing the business as without interrupting the normal activities in the lab, the types of tests required, how to actually increase use of these facilities to test for COVID-19, the quality assurance, the biosafety, security issues, biosecurity, how to manage the data, the personnel and logistic and training. You will be able to see all the details in that link that has been given there. But what I would like to let you know at the moment is that in Africa, at least we have had the National Animal Health Diagnosis and Investigation Center in Ethiopia, which has actually demonstrated and provided support to the public health. They were able to do this because they've had capacity that has been enhanced through collaboration on the OA twinning program and undergoing also the testing for ISO 1720, and they have been certified by the WHO to actually handle some of the human samples. So that lab has been able to support the endeavor. Okay, when you come to animal health surveillance during COVID-19, I want to let you know that, as I said before, we must know that this is an emerging disease, and I told what it is. OIE has produced a document, a small report on how to telling you about the how to go about testing samples from the human side based on the widespread testing of the COVID, how you can go about to test for COVID in animals. But I must tell you that it is not recommended to go starting sampling animals testing for COVID. At least that's not a recommendation for the OIE. It can all be done under joint risk assessment between the public health and veterinarians. And if the sampling will be of value in terms of resolving issues of decision making of the animals that are going to be infected, whether they're going to impact human population or the animals are either endangered and need conservation. It's only at that level that you may need to go doing routine sampling in animals. Otherwise, it's not recommended. And it has to be done by by competent personnel trained using proper PPEs and other facilities that are there. The rationale for doing this, as I've told you, will depend on the epidemiological effort, epidemiological factors. Is the history there? Is there close contact with the humans that have been infected? is it threatening the endangered species? Are the animals being tested, for example, the minks, in mass production? All these have to be taken into consideration before one can consider doing testing in animals. And then we have got a suggested case definition of what a COVID-19 case in animals could be. We can have what we call a suspect case. That's when there's animal showing clinical signs of, let's say, nasal discharge, respiratory distress, coughing, vomiting, gastrointestinal disease, but also being linked to having been in close contact with the humans that have been shown the disease. Okay? If you have those, you can have as a suspect case. You'll only have it as a confirmed case if the virus can be isolated or show the presence of nucleic acid. Once this is done, the member countries have got the obligation to report to the OIE as it is described in the Terrestrial Animal Health Code, Chapter 1.1, which obliges that should you see such a case, you must report. But also, if you are going to do experiments with COVID in animals, you are obliged to also report to the OIE as it is described in that chapter. So, what's the guidance of protecting animal health workers? First of all, I want to let you know that at the beginning, when COVID was actually beginning to become a global issue, the OIE and the World Veterinary Association gave a statement to show that maintaining the activities of public health is important, and that it is important to support the veterinary activities in the context of COVID-19 outbreak. So, in case we have people who are going to work with this, what are the recommendations? We shall continue to facilitate safe trade of movement of animals in accordance with the Terrestrial Code, based on risk analysis, disease prevention, and trade measures for import and export. We should not introduce COVID-related sanitary measures because at the moment it's not really a disease of animals. It's mainly of concern in the public health. Unless, of course, as I've described there's a case that warrants. You should continue implementing the OIE standards under the World Trade Organization where possible, and apply administrative flexibility to minimize the impact of this impact where it may have a procedural aspect of trade. If you are working with wildlife, you look at the exposure risk. Is there contact exposure through hands? Is there aerosol exposure? Is there an environmental exposure through sharing facilities together? Then from that, you can map up your plan to prevent the transmission to mammals by either minimizing and delaying prioritization to handling those animals. You can postpone handling those animals, or you can adopt practices that reduce exposure. I want just to let you know that we have a website. OIE has got a link where you can get all the answers relating to animals on COVID-19. The two main principles, key messages I want to leave you is two main principles of action that controlling zoonotic pathogens at their animal source and embracing a One Health approach are the most effective and economic ways of controlling, mitigating their impact, and protecting people. These two are the crucial cornerstones, particularly with the prediction that 75% of the emerging diseases are of animal origin. I thank you for your attention.
Thank you very much, Dr. Sam. That was very interesting. And we will move on to yet another interesting presentation from Dr. Catherine, who is going to be sharing with us what it was like being at the epicenter of an outbreak of the pandemic in the United States. So, Dr. Catherine, over to you to share your slides.
Okay, can you see this, hopefully?
Yes, we can.
Hello, everyone. My name is Dr. Catherine Quisenberry. I am the Chief Medical Officer at the Animal Medical Center in New York. And I just want to talk to you about the on the grounds happenings during COVID in New York City and how it affected us in the veterinary industry in New York City. So I want to share with you the timeline of what happened and how this impacted how we responded. As you know, COVID started entering the United States in probably January, February. It was on the West Coast, and then it quickly moved, or it turned up on the East Coast. And so by end of February, early March, we were having a lot of cases in New York City. So on about March 7th, I'd just gotten back from a seminar in Mexico. The governor of New York declared a state of emergency. And then we had about a 2-week period between the 7th of March and the 20th of March when everybody was obviously very concerned about COVID, but we didn't know exactly how it was going to affect us. And then on 20th of March, the governor implemented pause, and that was his executive order where all non-essential businesses closed down. Veterinary medicine was considered essential, and we were open for care. However, at that point in time, we didn't really know what that meant other than emergency care. And for the first 2 weeks, it was very confusing to everybody on the ground, what we could do, what we could not do. It was through our state veterinary medical association, we did work through that we could give vaccinations because that was considered to prevent infectious diseases and important for public health. So that was allowed. The 23rd of March, as our previous presenter talked about, the New York State presented guidelines for COVID testing of animals. And what they were trying to do was to prevent, excuse me, a mass testing of animals, and they were afraid this would cause a lot of public concern. We knew that it could obviously be found in dogs and cats, and of course in April was when the tigers at the Bronx Zoo tested positive. So, but they put in strict guidelines. So we had to go through the New York State vet to get approval before we could test any animals. That 2-week, or I would say 10-day period between the 20th of March and 1st of April, we were very concerned about how we were going to handle our essential workers, because the outbreak in New York City was skyrocketing at that time, and our real concern was to protect our own workers, and we didn't know exactly what to follow, what guidelines to follow. So on April 1st, New York State put out guidelines for essential workers returning to work, and I'll talk about that in a minute. The 15th of May, 6 weeks after the guidelines were put out, New York State began the phased reopening, where the state put out a series of metrics that every section of New York State had to meet before we could reopen. And this was based on the rate of case positives, a hospitalization rate, the death rate. So each part of New York had to meet these metrics before we could reopen. New York City, because the outbreak was so bad here, we had a delay in the phase 1 reopening. So that was delayed till June 1st for New York City. At that point, veterinary medicine could reopen to all care, but it took us another 2 weeks before we could really understand what that meant. We had to really, the New York State put out a series of guidelines that we had to meet. So we had to follow a very, very detailed list of what we had to do in order to reopen to all business. Very early on, we set up what are our goals during COVID, and we came down to 3 essential goals. The first and the foremost was safety. We determined that keeping our workers, our veterinarians, and our support staff safe was the most important thing, because without our workers, we could not provide care. And then, of course, that would affect our financial stability. We also made it a goal to keep the clients safe. The clients had to be assured that we had health safety protocols in place, that they could be comfortable bringing their pets here, that they wouldn't be exposed to COVID. We are a 24-hour facility. We're open 365 days a year. So we had to look at round-the-clock ways of ensuring that all these health requirements were in place while we are still providing essential care. We are a teaching hospital. So this obviously affected our teaching programs and how we conducted lectures. We have an intern class of about 25 interns every year and about 25 to 30 residents with our staff of about 50 doctors. So we had to ensure that we continued with these teaching programs. And then ultimately, of course, we wanted to remain financially stable. We wanted to ensure that we had enough business coming in to protect the jobs. We wanted to avoid layoffs, and we were successful in doing that. So first and foremost, all veterinary services in New York City shut down to clients. No clients or visitors were allowed to enter the building during pause. So we shifted our building is right in the middle of on 62nd Street. We don't have a lot of parking, but we are fortunate that we do have a parking lot. So we set up tents in the parking lot. This was in the early part. This slide was in March, April. You can see people have coats on. So it was, it wasn't pleasant for clients, but we set up heating out in the tents so the clients could stay outside. The New York City Police Department also allowed us to have clients pull up along our curve and wait in their cars for their animals while we took their animals upstairs and did the examinations. We set up a stop at the door, and we have workers, we called them facilitators, that their job was to interview every client that came in to find out why the client was there. Nobody was allowed past that facilitator. We had to move most of our, not most, but some of our working staff down to the lobby level to, of course, everything shifted to phone. So our people were spending a lot more time on the phone. So it was a big work shift, and trying to work through that was very, very difficult, because remember, this happened very, very quickly. We had like a 2-week ramp up to try to get things in place to shift all our business. We have assistants that would, in PPE, transport the animals from the clients up to the veterinarians. Again, our primary concern was safety. So we had to put into place the protocols for sick employees, and we did have a number of employees that did come down with COVID. So obviously all of our employees were very, very concerned about their own exposure to COVID. So we had to work with the city to understand what the requirements were when these sick employees could return to work. And the city did provide us guidance before the state did, actually. And this was when COVID was really taking off. And at that point, the tracing contacts was not even implemented anymore because it was so widespread. So at that point, if an employee was sick, the guidelines were for exposed employees, just for them to monitor their temperature and for any signs of COVID. And then if they didn't show signs, they had to leave work. We had to look at our environmental cleaning and disinfection protocols. And the state ultimately put out a very, very detailed list of what we had to do for environmental cleaning. And we have to be able to produce that to the state to show how we're cleaning the environment. Our supply of personal protective equipment in the early days of this outbreak, when it was at the peak in New York City, the PPE was very, very short supply. So we had to make sure that we had a supply chain from different vendors to make sure that we had enough PPE, and we did get some donations during this. We made it a requirement very early on that all our employees had to wear masks within the hospital. So by mid-March, beginning of April, we were providing masks to all our employees. In the beginning, it was difficult to make sure that we had enough, but we certainly made sure that everybody had their mask. And then social distancing at work. We had to do things like staggered work hours. We had to expand into unused workspace. Since we no longer had clients in the building, we started utilizing examination rooms as workspace for our employees. We continue to provide 24-hour emergency care. We established an emergency hotline where people, if they were worried about their pets, they could call in. They didn't have to come here, and that worked well. We're no longer using that. And the biggest change was the communication with our clients. Everything shifted to telephone communication and a huge push into telemedicine. Telemedicine now is a major platform that we're using. And there are many telemedicine platforms out there, but we had to do a gigantic jump into the telemedicine platform during COVID. Scheduling changes I mentioned, and then teaching. Of course, we are a teaching institution, so we had to shift to online platforms for teaching, such as Microsoft Teams and Zoom. This is one of our doctors. Again, during COVID, we still have pretty close contact in the workspace. So again, everybody's wearing masks. This is a doctor with an intern here taking notes in our ICU. Again, everybody is given sort of different workstations and try to stay in their workstations at work during the first part of the epidemic. And again, financial stability, protecting jobs. We ultimately did have to put about 10% of our employees on a furlough for about a month, but we were able to bring them back from furlough. This was during the worst part of pandemic when business was really down, but then we were able to open back up. But that was our goal, to make sure that everybody stayed employed. And interestingly enough, across all the United States now, veterinary medicine is probably busier than it's ever been. We're not sure why, but this is happening. So what are we doing now? The COVID precautions, we are done now. After New York City and New York State opened back up, we had to shift into long-term. And so again, we're still using the tents. Our tents now with the hot summer months have shifted to netting. In our tents, we provide fans. Since we're now doing everything by phone, we have to provide charging stations in the tents to make sure that we can keep in contact with the clients. We still use the facilitators. Most of our interactions are still with clients outdoors. So we bring the pets up and then bring them back down to the clients. We had to institute health screening. So all our employees are filling out health screening forms every day before they report to work. We are allowing some clients into the building now. The clients also have to fill out a health screening form, and they have to undergo a temperature check, which we do with a non-touch thermometer, and then they get a little badge that they've been screened. It's 1 client per pet. These are emergency clients. They're allowed upstairs. Our waiting rooms are set out for social distancing. We have clear demarcation on the floors where people can stand, where they can't stand, where they can sit. The clients, again, we've put up, you can see there's a barrier with the little yellow stickers. We put up barriers in between clients, and the middle picture shows a barrier in between doctors, the plexiglass barriers. And again, on the right, the stickers where the clients can stand and the barriers between the clients and our employees. We have signage all over the hospital, different types of signage, trying to be very, very clear about what people have to do, what they can't do, and about COVID precautions. And ultimately, of course, the goal is to provide care. And we are doing this, we think, to the best of our ability. We do a lot of seeing eye dogs for disabled people. But we are providing care. It's an ongoing situation. We're still doing this. We're evolving as we go. But I think the whole key to how we've responded is we've had to be very fluid to the circumstances and change as things go. So that's how we coped. I hope that you picked up some little pointers here, and I'm happy to answer any questions later on.
Thank you so much for sharing that with us. That was quite interesting. Right now, we will move to my colleague from Ghana, Dr. Emmanuel, who will just be sharing some biosafety program that has been implemented in Ghana. So I will be sharing your screen, your slides. Feel free to just let me know when you want me to move it.
Good, I'm ready, please.
Yes. Over to you.
Yeah, good afternoon, everyone. Yeah, my name is Emmanuel Kujo. I'm a veterinarian working with the Veterinary Services Directorate of Ghana. And I'm glad to share with you a biosafety program that is keeping veterinarians and support staff who are involved in testing for COVID-19 in Ghana. Yeah, the journey to this COVID-19 pandemic started somewhere in 2013. In 2013, when the Canadian government, through Global Affairs Canada, came to support the Veterinary Services Directorate with containment facilities at Pont Tamale, Accra, and Takoradi. At the time, the focus was on controlling and building capacity for testing for anthrax, avian influenza, and African swine fever. Little did we know that few years later, these containment facilities were going to be at the forefront of the fight against the COVID-19 pandemic. Yes, I must say that these three high containment laboratories in Ghana were well positioned, and they have impacted so much in supporting Ghana Health Services to meet its demand for testing for COVID-19. The training we had from the Canadian Food Inspection Agency's labs in Lethbridge and Winnipeg have helped us to carry out our laboratory assignments. Now, as you can see in the picture, we have this modular container labs. We have both biosafety level 2 and 3 labs fully equipped. Next is the ground floor of the BSL3 modular facility. You can see the entry door. We have the pre-entry room where the scrubs, laboratory personnel change into their scrubs, move into an ante-room, through to the shower room, don in PPEs, move into the containment area to carry out specific tasks, and go through the exit procedures, and finally exit the containment facility. Now, to succeed in these operations, we have outlined laboratory operations. First of all is the responsibilities. A clear organizational structure was set out, and each person understood the responsibilities of all who work in and out of the BSL3 work area. Access control was taken seriously and is being controlled by the laboratory directors. The access is strictly restricted to persons who are properly trained to use the biocontainment facilities. We also put in place practices and procedures, and this calls for the development of SOPs, standard operation procedures, for handling and storing viable biological materials, sharps handling, waste handling and disposal, decontamination and housekeeping, access, entry, and exit from the BSL-3 laboratory, donning and doffing of PPEs, and further incidents response. As you can see in the next picture, we have 2 laboratory staff working on COVID-19 samples at the modular container lab. They have done in their powered air purifying respirators. We also had a third element, which is the policies and guidelines. We developed policies and guidelines for the biocontainment level 2 and 3 laboratories with the help of our collaborators from the Laybridge and Winnipeg labs in Canada. The OIE guidelines for animal health laboratories, which Dr. Bakusama gave a detailed analysis of, also serve as a guide for us to do our COVID-19 testing in Ghana. Now, for us to begin the testing for COVID-19, we carried out a risk assessment. And this risk assessment followed the risk assessment matrix, which is based on likelihood, severity, and frequency. In risk management, we follow the AMP model, A standing for assessment, M for mitigation, and P for performance, which means we continuously review and improve our procedures in the lab. This all started with gathering information on our hazard, which we have identified. We are talking about SARS-CoV-2, which is the causative agent of our COVID-19. We had a vivid description of this infectious agent. We also knew the laboratory procedures to be used with regards to centrifugation, work with sharps, waste handling, freezes, the type of equipment to be used, which is autoclave biological safety cabinets, and then the description of the conditions of the facility where each work or task is to be conducted. And we also describe the relevant staff competencies, training, experience, and aptitude of personnel. Yeah, the description of the virus, we are all very familiar with. The risk assessment keys were based on frequency, probability, and severity. And we gave scores to all the tasks and hazards before starting the testing of COVID-19. One, sample reception. The risk assessment was done, and we took into consideration these various elements. The packaging, we checked the packaging for leakages. We wear our PPE, we decontaminate the outer surface of the packages, we record sample information, the laboratory ID, date of submission, do all the paperwork before we transfer those sealable containers into the BSL-3 laboratory. Now, our risk assessment showed that at this level, at the sample reception, the total score was 8, which was low. And some of the mitigation measures put in place were the use of PPE, use of spray bottles filled with 1% Vecon or 0.5% bleach solution for decon. And then we had a separate office for paperwork from the actual sample reception room. Point number 2, entry to the BSL lab with the samples and the materials. Yeah, we followed the outline tags, and the frequency here is also low. We score 4, and here the risk mitigation measures were SOPs, the training documents on biorisk management, the documentation on entry, exit, and then the proper use of PPE before entering the containment facility. Step 3, the processing of samples and the performance of RNA extraction using the GeneAid Spin Column. Yeah, this task scored 24, which is middle, and the steps we took there was to open the sealed containers in the biosafety cabinets. We add 1,000 microliters of PBS to the sputum. If they are swabs, we don't add the PBS. We process the samples and transfer 200 microliters into cryogenic tubes, avoiding aerosolization. Then after, we add lysis solution and follow the RNA extraction protocols. So here, the risk mitigation measures were our safe working procedures for handling chemicals, the biosafety cabinets operation, pipetting, and then the use of the protocols for RNA extraction. Yes, then the 4th task, which is the RNA extraction, the washing and elution. These are also steps that have scored low risk score of 12. And the mitigation measures here are just the safe work procedures. We make sure that all the steps are followed with due diligence. Then finally, exiting the samples from the BSL-3 laboratory. We first of all decontaminate the surface of our template tubes with 0.5% bleach or vacuum solution before taking them out of the biocontainment laboratory facilities. The score, the risk assessment score here is low. And then personnel will exit from the BSL-3 through Doffing. There are a series of steps that one has to go through to get out of the biocontainment laboratory lab and get the RNA templates to the biocontainment level 2 lab for the PCR analysis. So once we are in the biosafety level 2 lab, here the risk assessment score is 16, is middle. We use our regular PPE, lab coat gloves, face masks, eye protection. And then our disinfectant, here we use 0.5% bleach. We don't encourage the use of alcohols here because they allow the nucleotide to stick around. So the 0.5% bleach is good for working with our PCR reagents. Then our PCR machine, which is we are using the Biorad CFX96 instrument for running our test. And the following, you can see the PCR machine with its accessories. I must say that in Ghana, where I am in Pont Tamale, we don't have uninterrupted electricity power supply. So the equipment on the left, which is an online UPS, is a backup system. It can run for 5 hours. before the battery runs down. So our PCR machine is always in safe conditions. Even if the national grid should go off, we'll still have a backup to finish our test runs and data analysis. So we are pretty safe and good to go. I thank you for your attention.
Thank you so much, Dr. Emmanuel, for that brief update on how biosafety program is being implemented in Ghana. I think to our final presentation from Professor Adebola Olayinka from ICANN, we have received a lot of requests around IPC guidance for animal health workers and veterinarians. So Professor Olayinka is going to be walking us through key considerations for health workers in the animal sector. Over to you, Prof. Olayinka.
Yeah, good afternoon or well, good day, everyone. So we're going to be looking at COVID-19 IPC considerations for veterinarians and animal health workers. Quite a bit of what I'm going to say has already been said by the first speaker, but this is to give us a background introduction to coronaviruses, which are large family of viruses that we identified in the mid-60s. And they've been known to infect humans, other animals. And we have different examples that are known to circulate in various animal species, whether in dogs, in felines, in pigs, in cats and the cat family. Now, a lot of these viruses are usually non-zoonotic and they tend to be species specific. But it's been found out that there are a few zoonotic coronaviruses, and the word zoonotic here means that they are transmitted between animals and people. Two classic examples that have caused epidemics in recent times before the COVID-19 is the SARS, which was found to be transmitted from civet cats to humans, and then the MERS-CoV from dromedary camels to humans. To date, 7 coronaviruses have been shown to infect humans. Now, the SARS-CoV-2, which is the causative agent of COVID-19, has been shown to be 96% identical to a bat coronavirus. And recent research has shown that different animals like ferrets and cats, when they were experimentally infected with the virus, they had the ability to spread the infection to other animals of the same species. These were experiments that were done in laboratory settings. There have also been studies on non-human primates, and it showed that they could actually become infected and also be sick with SARS-CoV-2. This was also an experiment done in laboratory settings. Now, generally, it's been found that mice, pigs, poultry do not seem to become infected with SARS-CoV-2, and they do not seem to have the ability to spread infection. Available data suggests that some dogs can get infected, but they might not spread the virus to other dogs as easily when you compare to how cats and ferrets are able to spread the virus to other animals of the same species. In this pandemic, we've had history of transmission from humans to animals. Sick owners of pets, dogs and cats, have been found to transmit the infection to their animals. And in some of the mink farms, it's been postulated that probably transmission happened from a sick animal worker to the minks. Now, the coronaviruses cause a wide range of illnesses, from the common cold to more severe diseases. And they've been said to be responsible for about 20% of common cold in humans. Currently, COVID is thought to have been primarily a zoonotic infection, and this is based on the history of the initial cases in Wuhan, where 55% of them had a history of connection with the seafood wholesale market. Coronaviruses generally affect the respiratory and gastrointestinal tracts. These are the primary target cells for these viruses. And so based on this, you have viral shedding from these systems, and transmission occurs through various routes and really targets the respiratory and gastrointestinal tract. So this is a diagram from Ahmad et al. That kind of tries to show us the model of transmission from animal to humans. The natural host thought to be the bat, and then different intermediate hosts thought to serve as potential reservoirs. And it's still unsure how it really got to man. Was it through food? Was it through close contact? That hasn't been concluded yet. But what we know currently is that human-to-human transmission is quite efficient. And the transfer occurs through different means, primarily through inhalation of droplets expelled from the infected person's respiratory tract, or contact with respiratory secretions, and via hands to the mucosa of the face, the eyes, the nose, and the mouth, especially if the hands have had contact with a contaminated environment. So through various normal activities, you could actually get the virus being expelled. So through coughing, you could have up to 3,500 viral particles being expelled through a single cough. By sneezing, you could get up to 1 million viral particles being expelled. Even the normal act of talking could lead to bringing out the viral particles. Singing, and even by breathing, people who are infected still shed a few viral particles. And so what are the things that facilitate spread and impact of the disease? One, you have environmental conditions. So in conditions where you have a lot of overcrowding, where you have enclosed spaces, inadequate ventilation, poor hygiene, contaminated surfaces, spread happens rapidly. In places where there's poor medical care and poor infection prevention and control, and here we are talking about the IPC measures in place in terms of their quality and in terms of access. And then we also have host factors. People who are older, people who smoke, people who have lowered immune and nutritional status or underlying medical conditions are more vulnerable to the infection. And then we have the inherent pathogenic characteristics of the virus itself. So what are some of the things that veterinarians and animal workers need to consider when you're talking about IPC? One, you want to consider the infrastructure. What are your animal care facilities? Your vet clinics, your farms? Are there changes, are there modifications that need to be made, especially in terms of hygiene, biosecurity measures? What are the general hygiene measures? It's been found out that wet cleaning is much safer than dry cleaning, because by dry cleaning, you tend to bring up a lot of aerosols, which people can generally inhale. And then what are the available resources that you have? What PPE do you have? What water and soap? What wipes do you have? WHO has generally, since the beginning of the outbreak, outlined a set of strategies that are meant to help to control COVID-19. One is the ability to screen and recognize the disease early. The second is the implementation of what we call standard precautions. These are precautions that you put in place as a routine, irrespective of a suspicion. And then additional transmission-based precautions as appropriate, depending on the procedures that you're performing. The other strategy that is important are the things we call administrative controls. For example, what type of SOPs do you have in your facilities? What type of policies? Engineering controls? What kind of gadgets could you have? The use of plexiglass, for example, is an engineering control. And then environmental controls. How do you clean and how do you disinfect your environment? So when we are looking at work with animals, there are some general preventive measures and some things we need to consider. For example, if you have sick animal workers, what do you do? Do they work? Do they have time off till they're fine? And then how do you ensure distancing? And then when you have sick animals, especially animals that have respiratory illnesses, what measures do you put in place? These are critical considerations that need to be thought out very well, especially for animal workers. How do you implement distancing? Where could you use physical barriers, e.g. plexiglass, just to reduce the risk of transmission? Other things that are generally encouraged is to avoid pets licking faces, licking the hands of people, and people avoiding the kissing of pets. The other thing is immediate washing of hands after any contact with any pet or any animal, or contact with their secretions, with their food, or with their feces. Then people need to refrain from touching the face with unwashed hands, and appropriate use of PPE, and adequate cooking of food animals. So when we talk about hand hygiene, it's a single very effective way of reducing the risk of spread of acquiring infections. Good hand hygiene helps to terminate outbreaks and prevents diseases spread by contact, especially if we remember that our hands are a key link in the chain of transmission. We use the hands to do so many things. For adequate hand washing, you need 40 to 60 seconds to covering all the surfaces of your hands, and it should be with soap under running water. So hand hygiene recommendations include the performance of hand hygiene very often. Like I mentioned, avoid touching your eyes, nose, or mouth with unwashed hands. You want to wash your hands after every task. You want to also wash it when your hands are visibly soiled. Additional key times include after blowing your nose, after coughing or sneezing, after using the restroom, before eating or preparing food or preparing medications, after eating, and especially after any contact with animals or pets. Even if all you did was pat the head of a pet, you should remember to wash your hands. And then before and after providing routine care for another person. These are moments when you need to remember to wash your hands. Then there's a concept of respiratory hygiene and cough etiquette, which talks about covering your cough or your sneeze. If you've got tissue, you want to cover with a tissue and discard immediately and wash your hands thereafter. If a tissue is not readily available, then this can be done into the inner flexure of the elbow. But after any contact with respiratory secretions, whether of animals or humans or contaminated objects, it's important that hand hygiene should be performed. And for those who have symptoms, medical masks are critical. Masks generally have been found to be a useful measure for source control. And so now most nations are actually asking that people should use masks in public places. And I believe this would also be important in farms and in vet clinics. Then appropriate distancing is critical. There's a lot of talk on PPE. PPE stands for personal protective equipment. And these are a form of barrier that protects the user against health or safety risk at work. So this includes items such as masks, gloves, face shields, apron, boots. The list is endless. But we need to remember that PPE can be a transmitter of microbes when they're contaminated, and they are not a substitute for poor practice, poor infection control practice. Then also, we need to remember that PPE have a limited lifespan and they need to be discarded after such a span is indicated. But very importantly, hand hygiene needs to be performed before and after removal of any of the PPE listed above. So what are other IPC measures that vets and animal workers need to think about? I mentioned administrative control, which are the policies and SOPs that address safety. And you're looking at safety of the staff and also safety of the animals. So some of the things that have been proposed are things like scheduled and enforced hand hygiene for staff, performing hand hygiene after contact with each animal, scheduled cleaning and decontamination of the environment, scheduled cleaning and disinfection of common use items, adequate ventilation, use of gloves and other PPE like mask, eye protection, aprons, boots as appropriate, and ensuring that these are appropriately or adequately disinfected after use. then it's important that staff understand how disease is transmitted, because then they can put in the appropriate measures. And then you want to protect vulnerable persons, both your staff and your animals, and you want to ensure a physical separation of animals that are sick from those that are not sick. So on this slide, I have a few images on some protective measures that could be useful. Hand hygiene is very critical. You can see animal workers using different types of PPE in their interaction with animals. And then the last two actually put a lot of emphasis on the need to disinfect, to clean and disinfect environmental surfaces. So in closing, I'm just going to go over the key messages, which are, it's important we all know and understand what the preventive measures are, and we practice hand hygiene as often as necessary. We learn how to perform respiratory hygiene and teach others to do the same. And very importantly, avoid touching your face with unclean hands. Environmental hygiene is also very important. And when you use PPE, you need to use them appropriately for it to be protective. And remember to wash your hands after removal. And if anybody feels they've been exposed, it's important not to run around or do self-medication. Follow whatever protocol you have in the country and call the hotlines. Thank you, and I'll stop here.
Thank you so much, Prof. Olayinka. That was a fantastic presentation and definitely very useful to our colleagues from various parts of the world that are treating animals, attending to farms. So I think we've gotten to the interesting part of this session. We have seen so many questions already being put in the Q&A section. Please keep your comments and questions coming. I will then, right now we're going into the moderated discussions. So feel free to direct some of your questions at my panelists. They have started attending to some of the questions, but so that everyone can benefit from it, I will address some of the key questions that have been raised in the Q&A box. So Dr. Samuel, I think many of the questions have really been directed at you. I think one recurring question is people are really interested in the African case animal event. I think people are particularly interested in that. I've seen quite a number of questions, and I know that you've said a bit about it, but for the benefit of other people that are not looking into the Q&A box, if you would like to share a bit about the Puma SARS-CoV report that was reported in South Africa for the benefit of our participants. Over to you, Dr. Samuel.
Okay, it's just one of the reports that was made by the delegate of South Africa. It's in a zoo, and the animal, I mean, there was a zoo worker who had signs of COVID and had exposure, was positive, and he was working in this particular zoo. And the animal showed signs of illness. And when they tested, they found it was positive. It's as limited as that. And because it's a requirement, because being an emerging disease, it had to be reported to the OIE that this animal has been infected with the SARS-CoV-2, just like the same case with the tigers and the lions in the US. The origin of the virus into those animals was from humans. So it's like that. But it appears like the feline family of animals, the cats, are more coming up as being infected easily, yeah, compared to other animals that we have seen. If you look at all that, what I've given you there is the feline and the canine species that are actually getting infected here. So that's all I can say, but there's a link that it can be shared later on from the OIE Africa website showing the Puma infection. Thank you.
Thank you so much, Dr. Samuel. Stephanie, this question really, if you'd like to take it for Africa CDC, this person just wants to know why we are not looking at, excuse me, other zoonotic diseases, which are quite common across the globe, and why we're just focusing on COVID-19. I know that we as Africa CDC are working on doing a special edition. So Stephanie, if you would just like to give a response to that before moving to the other questions.
Sure, absolutely. Yeah, we're focusing this particular series on One Health and coronavirus specifically. But as some of you may or may not be aware of, Africa CDC has worked to develop a One Health framework for National Public Health Institutes and Ministries of Health. And so we are actually hoping to discuss that on an extra call that we hope to hold in October. So it's going to be the last Monday of October, which I believe is the 26th. And so we will have an opportunity to go through that framework and discuss some of the other zoonotic diseases that have been prioritized across the continent. And we can actually talk about the need for potentially keeping something like these webinars going on in future to discuss other zoonotic diseases as well. So if these seem helpful for you all and you'd like to have us keep holding these, please let us know so that we can consider doing that in future. Over.
Thank you. So I think we can all agree that this has been useful. I've seen comment from some of the Vet Student Association and some of the veterinarians. So I think we as Africa CDC, we're committed to working on this and improving One Health institutionalization across the countries. So definitely we will look into further support through our partners and various experts across the continent and across the globe. So my next question will be to Catherine. I see that question on the chat. Just out of curiosity, somebody is wondering if any of your staff got infected, particularly from the workplace, not just the community, looking at workplace infection, if there was any report of your staff in your institution reporting a case of COVID-19. Over to you, Dr. Catherine.
Yes, thank you. Yes, we did have people in our workplace that got infected from other people in the workplace. And this was in the very early part of COVID when, you know, it's pretty pandemonium. We didn't really know what to expect. So in the very early days, in the beginning of March, we had, I think in total, we had about 10 workers that got infected. One I know, several I know directly from being at work, but the other ones were community acquired.
Thank you. Thank you for sharing that with us. I think there are lessons for us to learn as Africa and as veterinarians and animal health workers on the continent. I think this is a particularly interesting IPC related question, and I know that it's come up a lot in the work that we are doing across the continent. So I would direct this question at Dr. Olayinka. It's just wondering, out of curiosity, we know that there's been a lot of rumors around the use of face masks can affect flow of oxygen, and you can get carbon monoxide poisoning and things like that. So I think this is an opportunity for us to reiterate the fact that there's no evidence that that can happen, and just for you to share a bit about the use of masks and the safety around it. Over to you, Prof.
Yeah, thank you, Yewande. So, like you said, there's been a lot of misinformation about that, but there's really no evidence. Number one, as human beings, we don't bring out carbon monoxide, so there's no way you get carbon monoxide poisoning. Even the carbon dioxide we bring out is not, it's not toxic, so to say. But the other thing is that when you put on the mask, you're not totally sealed up. it's a mask. Yeah, if you check the mask, if you're using a mask right now, you'll find out that there's space. And we also talk about the material by the mask is made. Usually masks are they are made from breathable materials, which means that you're able to breathe through them regularly. They're breathable. The only thing is that they've got filters in between that reduce the what do you call it now? The penetrability of particles of certain sizes, which includes bacteria, viruses, and pathogenic agents. So masks do not cause any form of poisoning. You can actually use masks from morning till evening. I think many of us have done that. Sometimes it's on, and we do training through the mask, you know, still talking through the mask and doing all of that from morning till evening. And from February till now is August going to September. I don't think anybody has died of any carbon dioxide or carbon monoxide poisoning. So it's really a misinformation. Over.
Thank you very much. I think I can also add on to that to say that many of us as veterinarians, during surgery, we go on long hours of during the surgical procedure, and we have this on and nothing has happened to us. So it's the same thing. It really doesn't cause any damage. It's just panic and, again, false information. And this is why we as One Health people should always advocate for what is right. So fantastic. I think I'll circle back to Dr. Catherine, just a suggestion and to get your input on this. Could filling screening forms and temperature checks be used as a management tool for institution opting to reopen? That's to you. If it has been of any benefit to your institution, I'm sure that we can learn from that. Over to you, Dr. Catherine.
Yes, thank you. The temperature screening and the health screening is actually mandated by New York State in order to reopen. So we didn't really have a choice in this. So it took us a while to get the health form for the employees, and we put it online so that people can do it on their smartphones before they come to work, and then we get it in a central place in our human resources. And then as far as the client screening, we put first we were only doing it by a form, but then we felt it was very important for our employees to feel safe. So that's why we put in the temperature screening of anybody that enters the building, because we want our employees to feel that we are protecting them as much as possible. So since we put in the temperature screening of anybody entering the building, I think our employees have felt much safer that we care about their health.
Okay, fantastic. Thank you. I think just a lot of questions are coming on to reemphasize the importance of IPC. It's just questions around the definition of airborne infections, the duration of stay, and distance covered by the pathogen in the atmosphere. I think Prof. Olayinka, based on some of the work WHO is doing, if you'd like to talk a bit about SARS-CoV-2 in the context of droplet and airborne transmission. Over to you.
Yeah, thank you. So I know there's been a lot of back and forth on, is it airborne, is it droplet? First, I'll say whether it's airborne or it's droplet, it means that you inhale it. It's by inhalation. Now, the concept of airborne and droplet it's not a black and white kind of distinction. So there is an area in between, but generally it's thought that droplets are larger particles and they are heavier particles, so they travel shorter distances and they fall quickly to surfaces, whereas airborne are smaller particles, they float in the air for some time, and so the risk could be higher. Now, whether one thing we need to realize is that even by the very act of breathing, we are bringing out aerosols. Aerosols, as in we're bringing out particles from from our respiratory tract. These particles could have viruses in them if the person has a virus in the respiratory system, or it may not have viruses if the person at that time does not have viruses in the respiratory system. Now, as to whether those particles that are being brought out are airborne or droplets, it could depend on so many things. One, it could depend on the force with which it comes out. If it comes out forcefully, you are likely to have much more tinier particles than if it came out less forcefully. The other thing that could also complicate this could mean the airflow at that point in time. Is there a form of airflow to carry it for a longer distance, or there's no airflow? So there are so many things around it. But I think what is really important for us to know is to know that, one, I tell people that the virus is not just floating around in the air. The virus is in the throats or in the respiratory tracts of people that are infected. And so because it is in their throats, and like I mentioned during my presentation, they can expel these viral particles through talking, through singing, and that is really what has informed the enforcement by many nations on the use of masks, so that you kind of control the source. So irrespective of whether the person has symptoms, doesn't have symptoms, if each one of us is using a mask, then we are controlling the source of infection. So even if the person coughs, if the person sneezes, if the person is talking and is talking through the mask serves as a form of control and contains the particles. And so it doesn't get into the air and people are protected. So I wouldn't say we should trouble ourselves so much on whether it's aerosol or whether it's airborne, but what are the prevention measures that we need to use? And if we all use these preventive measures, whether it's airborne, whether it's droplet, we help to protect each other. Over.
Fantastic. I think we've had an interesting discussion. This final question, because it's been directed at our representative from OIE, Dr. Sam, if you would just like to take a go at it for the benefit of other participants on the call. It's just saying, what does OIE think about the transmission of SARS-CoV-2 to humans by bat? Is this true?
Well, we don't have any direct evidence to say that the virus can come from bats to humans. What we know is that the bats are a very rich source of coronaviruses, and therefore the likelihood of SARS-CoV-2 originating from bats is very high. But it is more likely that for that transmission to occur, it may have gone through an intermediary host. And which one exactly it is, there's still more work to be done to find out. So it's not absolutely true, but I can't say no because I don't have evidence either.
Thank you so much. I think, colleagues, if you will, on our first call, we did a deep dive into unpacking the virus. Those recordings, YouTube recordings are available on the website, www.africacdc.org. Look into events, previous events, and feel free to look onto the previous sessions where we talked a bit about the virus. So on that note, I think we've had a very insightful discussion. I'd like to say thank you so much to experts who have joined us on this session as panelists. Your presentations have been very useful. It's been a learning experience for myself, and I'm sure many participants on the call. So I would like to say thank you very much for being a part of this. I would also like to say thank you very much to Peter, who is the interpreter, who is providing simultaneous translation from English to French. So colleagues on the call, for the next session, be sure that we have French translations going on. And thank you very much, Peter, for being a part of this. Just to also say that there have been a lot of questions that are we only focused on COVID-19 as part of our One Health work. You may be aware that we have developed a One Health a framework to support One Health, particularly in National Public Health Institutes. And we will be having a special edition in October, like Stephanie said. So we'll be sharing the save the date and the flyers for that event. We'll be talking a bit about how we can better support member states with the support of our partners to properly support the efforts of One Health. We're starting to see that there's a need for sectors to work better in response to many zoonotic diseases. I think COVID-19 has been a learning experience for us, and rather than just let it be a learning experience, I think our aim as Africa CDC is to continuously support member states to be to ensure that there's enough capacity to adequately respond to disease outbreaks, which sometimes might be zoonotic. So on that note, I would like to say thank you very much to colleagues also on the back end who have made this this webinar possible. Thank you so much for being a part of this. And to all the participants who joined us today, we couldn't do it without you. So we say thank you very much, and be sure to join us on the last Monday of September for our next session. So thank you very much, and I look forward to speaking with you next month. Bye.
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 Yeah, thank you, Dr. Alimi. Bye.
Bye.
Oh, sorry. I was just
Thanks a lot for helping us set this up.
You're welcome.
All right.